Good evening, all. I am Dr. Gnana Murthy, practicing pediatrician in Bangalore, Koramangala. And today I happen to be in Nagpur. I just want to share my views about the respiratory tract infections caused by viruses. And we all know among the practitioners across globally, whoever practices in their practice, they see almost 85 to 90% of their chunk of practice is of respiratory problem only, out of which 85 to 90% are problem of viruses. And in viruses, we have different viruses affecting different parts of the respiratory system, let it be upper airway or a lower airway or a parenchyma. But it's very much important for us to differentiate which virus affects which compartment. And moment you make a diagnosis of saying respiratory tract infections, we need to be clear which viruses are caused of which compartment so that our management protocols, whatever we form, should help us in making a diagnosis and aiding the parents or children in treating child. And why do you think these respiratory infections are more vulnerable in a small infants? That's because of their immature immunity, wherein, because of the poor innate immunity as well as adaptive immunity, innate immunity allows all the virus to enter the body and accumulate there. At the same time, adaptive immunity will fail in eliminating the viruses. On the whole, there is a big load of viruses affecting the body, one. And number two, earlier the virus affects body, it causes epithelium damages of the respiratory tract infections. And earlier the viruses affects the infants. There, the response of the immunity will get skewed towards chronic inflammations, which lead to sequelae future also. We have seen some of the picture where the child get bronchiolitis following especially respiratory infections. If it persists long time because of problem involved here, they would land up in what is called as PIBO, that is post-infective obliterans. And also we have seen some of the viruses like rhinoviruses, though 85% it affects only the nose because of its adherent to the nasal mucosa, sometimes it goes 15% into the alveoli. And these viruses we also found out clinically, they can march toward child going for asthma. So, dear friends, it is very much important for us to make approach this case, whether it is involved upper respiratory tract or a lower respiratory tract or parenchyma. The reason is, moment you get some respiratory problem, most of the time people will say it's a pneumonia and it's been mislabeled wrongly. And moment you say pneumonia, people will harp on antibiotics. And that's where antibiotic been abused. So we have to be, as a professional, as a pediatric, who imbibe science, we need to be in a position to differentiate it is airway disease or it is parenchymal disease, so that our management policies will be more precise and also will tell us how to practice antibiotic stewardship. Now, coming to this, as I said, whenever you approach a case, there has to be algorithmic approach in anything, in any field for the matter. When you go step by step, you start with history, have a detailed history, see, collect the informations how the evolutions happens. The history will tell you the evolution. Once you have evolution, then you go for examination step by step, without missing any part. That's what we've been taught all along in our medical days, which you should practice throughout a lifetime also. With these two armamentarium with us, then we need to try it clinically. And there are certain clues where you can make out this belongs to upper respiratory tract, or this belongs to lower respiratory tract, or this belongs to parenchyma. The way the child manifests clinically, we should pick up that. Say, for example, upper respiratory tract. It is a hollow tubes where it makes more noise. So most of the symptoms around airway tubes is you get noise, you get more of cough, The reason is it is a tube-like channel which is ciliated, and the nature always does whenever there is a good amount of productions of phlegm, whenever your virus get trapped, it has to be coughed out. So if it is upper respiratory tract, you will get a brassy cough. That is upper respiratory tract. At the same time, if it affects the vocal cord area, you will have a problem with inspiratory stridor. This is the problem with croup. So with this, we can make out child have a croup. At the same time, it goes to lower respiratory tract. You also get cough. Initially, begin with, you'll have a dry cough. Later on, you may get wet cough. But thing is, here you get wheezing. That is, each time when child breathe out, expel out, it causes a sound. So you are breathing out. This is called as wheezing. This way we can make out whether it's a lower respiratory, upper respiratory. And based on the distress a child going through, you will have a different clinical pictures, what is called a scoring. We can make out how much the problem child is going through, whether mild, moderate, severe. At the same time, if the virus jumps into the parenchymal alveoli, which is a alveolar balloon, where due to inflammations, there will be collection of the fluid and cells leading to edema. What we have heard in our medical days, grey deputation, red deputation, consolidations, and then resolution stage. It is only in the resolution stage where child can get cough and bring out phlegm. But however, the receptors in the alveoli are very poor, so you may not get good cough. But there is a clue is, once the balloon gets consolidated, the exchange stops occurring. Its main purpose is to have a gaseous exchange from the airway to the bloodstream. So that's get cut off. So our body, our lung system, which is supposed to produce, give oxygen to the body, has to produce the same amount of oxygen all throughout to the body. So what happens? There will be tachypnea. The child starts breathing faster, hurried breathing, and child becomes more toxic. And as the symptom worsens, the child even can have a cyanosis also. So this is how we have to differentiate. And second thing is, whenever you examine, a clue for a doctor, whenever there is a tachypnea or whenever there is a CREPS, what we can make out, don't harp on making a diagnosis of pneumonia. So just finding a cracks could be coarse crops or fine crops. So we need to differentiate this so that you don't harp on pneumonia and start antibiotic. So this is regarding triaging. Then comes the picture of how to make best use of laboratory armamentarium. Now, in approaching a case of viral infections, there are two important things we need to know. One, is it where the anatomical localization, is it in upper airway, lower airway or parenchyma? And number two, for our management, we have to know whether it is what etiological diagnosis. So for anatomical diagnosis, we make best use of radiology, wherein you can go for X-ray, you can go for ultrasound, you can go for CT scan, and there are various classes are there where you can make out how it, because in science we all read, to signs from the radiology we can make out whether it is a croup conditions where we get steeple sign, or if it is affecting the lungs, we know we can differentiate viral pneumonia by bacterial pneumonia with certain clinical clues we get through radiology. And then the best part now what we have is point of care by using ultrasonogram will tell us exactly what is happening and also tell us whether child is going for complications. So that is radiology. Whereas come to etiological diagnosis, we can go for confirmation or proving viral factors by you have a rapid antigen test, you have a PCR test where you have both singleplex, multiplex, and then down the line various tests which will tell us exactly which viruses are harboring. So based on making diagnosis, again there will be some pitfalls when you depend on the PCR, because it will pick up whether a dead virus or live viruses. So we cannot know what exactly happening, and it also picks up the viruses which are normal commensals of the tract. So we cannot tell it is a real pathogenic virus or a non-pathogenic virus. So you need to have a little science behind that, and making best use of this armamentarium, we can make a diagnosis of the child having problem, and our treatment can be geared towards it. So this is regarding proving a case of a respiratory tract infections, whether it is affected which component and which virus involved. And based on that, now when you go to the management per se, you have to also see child as a whole, how the child is presenting to us, and also make best use of what is called as SPO2, which will demark us whether to tackle the child immediately or we can tackle little leisurely. So again, you have an algorithmic approach for it. So that's again, it's a big chapter, a big subject or a big topic which needs some more time. So regarding that, next time when I meet you, I'll explain again. Thank you for your patience hearing to me, and good day.